to get there around.
Siéntate, desde aquí, así deja, sí. No, desde aquí, pues somos 6. Entonces deja... The session is open for discussion, please. Yeah. You have a question?
Is it working? Yeah. I have a question for Nathan. What do you think about contralesional activation as maladaptive?
Sorry, what was the last word?
Contralesional, like enhancing contralesional activation as maladaptive. So instead, you're saying that you want to boost contralesional activation as a way to improve motor function in these patients, but sometimes in the literature we see that contralesional activation can be maladaptive, so you'll actually be doing it the other way around. So what are your thoughts about that?
Yeah, so... Okay, sorry. Yeah, I think that it may be that the contralesional recruitment is actually maybe a short-term mechanism for the brain in order to, the tumor's growing too aggressively. And so maybe what will happen is over time, or what I hypothesize happens, is that over time, the brain prefers to actually try to recover its native function. But at this moment, I don't know how best to follow these patients, because we have to balance sort of our intervention timing versus allowing the brain to perform its native tasks.
To Emmanuel together. You've seen Emmanuel's comments on the EORTC study, particularly with the respect to extent to resection. What are your comments on that from an oncology perspective, and how much do you share the views that Emmanuel's presented?
I agree with, actually, do you hear me? For me, the RTOG study is not a study on when to treat patients, but how to treat patients. So I agree that there are limitations, but even with these limitations, I think that the information that adding chemotherapy to radiotherapy when you decide to treat a patient is an important information for the community.
Yeah, I just do not understand why they just keep out the extent of surgery in the analysis. It's just, there are so many weird things in this paper, as I show. We don't know when they have been treated. We don't know the role of the surgery. The cutoff of 40 years is disputable, so I'm not sure it's so useful for treating patients. And we don't know absolutely the functional status of the patient, because in the long survival arm, it's almost 14 years. So we don't know how are the patients after the 14 years. So it's not very useful, I guess.
Regarding the regional heterogeneity of the tumor, do you think it's recommended to always perform multiple trajectories in biopsies? And second, is the quality of tissue prelevated at QSA sufficient for good molecular biology?
For us as researchers, I think if you get different pieces, it's certainly always of interest. But I think it's the question, what will change in the treatment if you have more information which will go beyond the markers which are that are found always in all different parts, like the early ones like IDH1, TERT, and 1P19Q. So which information, are you using this information or not? For us, it's always interesting. The issue about QSA, it is very difficult for analysis because for mutation analysis, you will have all sorts of things in there, so you will have dilution of the information. So this is not, it's not very helpful. Of course, if there is nothing else, we can try. But I don't think it will not go into routine because you don't know if you don't see it because it is diluted by normal tissue.
Dr. Sanai?
It's a question for Monica. So I'm interested in this concept of the hypermutated phenotype. So basically, for a fraction of these low grades that are treated with temozolomide, they undertake some sort of transformation and accumulate a massive number of mutations. And that seems to give them their own phenotype. And I think in the reports that exist, they actually have certain pathway activations in common. I think one of them is mTOR. So it seems to me like you have a treatment that then induces a predictable phenotype in a subset of the tumors or tumor cells. And that predictable phenotype itself could have predictable pathway activations that are targetable. So do you think, number one, that this is actually what's happening? And number two, do you think that that actually instructs us in terms of what to target that particular subset of tumors with?
So I think for this mutated phenotype, I mean, it's found in a subgroup of the tumors at recurrence under treatment. It is difficult to say from the patient population that has been studied what the percentage would be. I think it's probably below 10%, given that the rate of reoperation is probably not so great. So it's a highly selected population that we see in those studies. Then I think what is very interesting is this mutated phenotype. We can see it probably because there is a reduction of clones, that this clone grows out because maybe it went through a bottleneck. This is the reason why we can see it. But I think it's an identifiable subgroup, and I think it would be worth to study whether they could profit from certain treatments. And I think this is something that we will see, but I think what happens at the moment, there are trials where they look for the mutated phenotype, and then they will probably do, because there will be more antigens potentially, so they will go into immunotherapy. I think that's what they're using for. But I don't know, they probably should also look whether they have the PD-L1 methylated or not. I think this is something that needs to be taken into account. So, but I think it's a good idea to do that, but it will be a small subgroup, but maybe it will give us more information.
I'm not an expert at all of molecular biology, so I don't understand everything, but in the Suzuki paper, I was surprised that there are, in the different branches, the CIC gene is mutated at different spots. So how do you explain that? Is it that there is a mechanism that specifically targets this gene and at different positions within the gene? Or is it that the mutational process targets all the genes and only the clones with a mutation in this gene will be selected in the evolution? You see what I mean?
Yes. So I think first that we see it on that to see different mutations coming up in the different branches means that it's a later event, but it seems to be of benefit for the tumor. That's why you see that even if you have independent progression. And that means potentially you can target it, but for the initial tumor it was not necessary because it was not there. So this it probably will quickly also provide. I mean, if you are able to target it, we will probably select for the next resistance.
Yes, but my question was why the mutation in the gene is at different spot. I mean, there is two possible explanations. Either the mutational process is targeting randomly any genes, and only the CIC gene clone will be selected, and by chance we will have several clones with different mutation in the CIC gene, or is there a specific biological process that specifically target the CIC gene, explaining why we found specific mutation in this different mutation in this gene. It's two different kind of processes, and I don't know if there is some data allowing to make the difference between these two processes.
It's the progression. So you will only see the mutation if it gives the advantage to the cell. I mean, with some exceptions, there is you can also have passengers which are together with something else, and that's why you see them. But it means that the inactivation of this gene is of advantage, but it's something that happens later, but it will be selected for by different clones. So it is something, you see this also for P53. Sometimes you can also see this for ATRX, that you can inactivate it by different mutations. But it is something which seems to be of interest for the tumor to have in order to progress out. If it's only...
It doesn't mean that there is a process that specifically targets this gene.
No.
They are just selected by the evolution.
It's a selection. It's a selection.
Thank you. Any question?
Well,
I
have a question for Joanne. I've seen that in your papers now, what velocity of growth, you talk about millimeters. I was stuck at the cubic centimeter period, so why do you shift from volumetric to millimeter linear expansion? What is the rationale? And can we still measure the volume in cubic centimeters? Is it valid, still valid, or?
Okay, that's an important question. For sure, on each MRI, we make a clear measurement of the tumor volume in cubic centimeters. So, as Emmanuel showed, the spontaneous evolution of the low-grade glioma of its volume in cubic centimeter is exponential. Okay, so thanks to biomathematical modeling, we decided to convert the tumor volume into a mean tumor diameter. But we measure first the glioma volume, then we transfer it into a mean tumor diameter, because comparing the exponential glioma growth volume, the evolution of the mean tumor diameter is linear. So that's easier to envision a different growth speed, because it's visual, and to change in a evolution break in the line which will show an increase in aggressiveness. So that's the reason why.
We have time for one question more.
Another question about biomarker. Do you think that mutation TERT promoter could replace or substitute the searching of codylation?
There is a problem with that, because in glioblastoma, 80% of glioblastoma also have a TERT mutation. So, but I think this would be a possibility. Otherwise, in the IDH mutant, it's probably a possibility.
Yes, but in the subgroup with IDH mutation and codylation, there is no the searching of TERT promotion is negative.
I think that if you combine IDH and TET mutation, you can identify most of the codelated patients with atherix. But there is also a small subgroup of patients, which was described by the in the New England paper from the San Francisco group and the Mayo. It's a small subgroup of patients with no codelation and IDH mutation and TET mutation who looks that looks of also very good prognosis. So I think that for the moment, the best is still to look at the 1p19q correlation with a good technique.
Well, one more, please.
The last one for Jean, about the anti-epileptic therapy. Could you tell me what is your opinion about, because the resection the total resection avoid the epileptic genesis and the epileptic seizures. What is your opinion about post-operative anti-epileptic therapy? For example, do you stop totally, for example, or do you continue low doses and so on? This is from the practical point of view.
So that's a individual personal approach, because to my opinion there is no rule. Following a case of complete removal on MRI of your low-grade glioma, I continue the same anti-epileptic therapy postoperatively, the same as preoperatively during a 6-month post-op. Then at 6 months post-op, I have my MRI, which shows a complete removal. I have a 6-month duration without no seizures. Then at that time, if the patient is okay, I will decrease the treatment and I will stop it in a 4 months duration period. That's my rule.
Okay, a coffee is waiting for us there. Thank you very much, all the speakers, for this exciting presentation.